Well, thank you all for attending, and Rick, thank you for the invite. I really appreciate the time to come and talk to you. I got the call from Rick a couple months ago, I think, and I remember Rick actually because he was this, I was in a dental student, and I knew Rick because he was this big guy that walked around oral surgery. He was one of the oral surgery residents. We all thought he was amazing, so I'm glad to be able to come here and build up his ego. Yeah, perfect. Yep, I got all the comments. And he also said, like, just come and give this talk. I said, how long is this talk? He said 30 minutes. It's like, so you want me to pare 3 days worth of information into 30 minutes? Seems reasonable. So we're going to move fast. I'm assuming that everyone has some understanding of the airway space and frenectomies. And I'm just going to focus, we have such a great panel of speakers, I'm just going to focus more on just our surgical technique and what we do at our practice in Cary at the North Carolina Tongue Tie Center. We'll skip all the disclosures and stuff because I don't really have time for that. So let's just move on. So on our short journey today, I'm just going to go over our approach and philosophy of what we do at the Tongue Tie Center. And we've been at this for about 7 or 8 years now, and we've sort of gone to the courses and gotten all the forms, and then we sort of kind of modified things as we went along. The unique aspect that I bring to this to the table is that I also have a PhD, so a lot of this is born of research. We do a lot of clinical research in our practice. We've published a lot in the past year, and it's taken 6 or 7 years to collect this data, and so now we're out there and trying to improve things, and I guess improving the candle or the light bulb, whichever one we're working on today. We'll go over diagnosis, surgical techniques, stretches. I'll just kind of go through what we do at the practice. Now, I realize that when I say research, I can already, at every talk I give, whether it's here in the US or abroad, I always see the eyes glaze over a little bit. So research tends to be really boring. And so what I'm going to do is I'm going to talk about our approach and how we've used research to shape or change our protocols. And hopefully that is useful to people here. We're going to try to answer the question about what's actually new about all of this. I'm on pediatric dentistry groups on Facebook and so on and so forth, and there's always the people who are like, yep, I win, and nothing new, same thing I learned and thought about 30 years ago, so I left, and there's nothing new. So I'm going to try to point out what actually is new about this with research and how we can use that to kind of, I think ultimately what the research does, it helps us all become better clinicians, it helps us get patients the specialized and customized treatment that the personalized medicine that we want them to have, or personalized dentistry, I guess in this case. And we'll talk about how that research has sort of changed our protocols, what we used to do and what we do now. So a little bit about our practice in Cary. We do look, our Tongue Tie Center is a separate standalone practice, but it is integrated with our pediatric dental practice. So we function together, and from a research perspective, our Tongue Tie Center is our experimental group, and our pediatric dental practice is where we draw control patients from. So you always want to be able to say what works and what doesn't. Does myofunctional therapy work? I think it does, but you need to be able to show that in comparison to those who didn't have myofunctional therapy and those who did have myofunctional therapy, or any other procedure or technique that you're doing. You got to be able to show a difference, right? You can't just do the same thing and have it be the same in both populations, but just that you're just a good salesperson. You can convince people to do this thing that maybe they need, or maybe they don't, or makes a difference or doesn't. So I think we all, I know that all the people at this symposium are here to provide the best care and are really wanting to make sure that we advance that and make sure that we provide the care that we need, get everything they need and nothing they don't. So we do look for labial lingual. Buccal is in parentheses because we are doing some research projects on that, but we do not currently release buccal restrictions because there's no evidence for that. We'll talk about that in a little bit. We do see patients from infancy all the way up through teenage years, as is pretty standard for a pediatric dental practice. And the majority of our referrals comes from pediatricians, lactation specialists, SLPs, myofunctional therapists, and we do take a conservative approach. We want people who have a problem to see the specialist in that area. Does your baby have a breastfeeding problem? Go see a breastfeeding specialist and see if you can resolve some of the problems first conservatively before we start moving towards a surgical technique. We are conservative and collaborative, so we are known as a very conservative practice. Our reputation is that if you don't need it, Dr. Ray will tell you you don't need it. But we are also very evidence-based, and I found that as we've built up our evidence and we've talked to parents during consultations, what we find is that the number of questions they have becomes fewer and fewer until now they really don't have any questions. The most common comment I get is that, nope, you've explained everything thoroughly, we're ready to proceed, or where you want to take a minute to try some other things. And then we want to make sure that we take a realistic view of what the outcomes should be. I find that having accurate expectations on both the part of the parent and the provider is going to give you a better outcome more than anything else. We use a three-pronged test in our, as our philosophy, whether we proceed with a surgical procedure or not. And the first one is that there has to be restrictive anatomy, and we find that in our clinical exam. There has to be restrictive anatomy that could lead to some of the symptoms that we see. There have to be current symptoms, and both words are important. It has to be current. We do not revise for future problems. We don't have breastfeeding infants that we're going to revise so they don't have speech or eating issues later. We don't do that. And then there has to be a symptom, and actually the part I should have put in here also, it's got to be a symptom that you care about. So if your child can't eat meat, but you're a vegetarian, that may not matter. So we talk to parents about, what do you care about? What do you want for your child? And obviously when we're talking about breastfeeding and infancy, that is a major problem because we need to have these babies be able to grow and do well. But as the kids get more autonomy and they get older, and some parents care about speech things or some don't. And some care about sleeping and mouth breathing and some don't. Some care about eating problems and being able to lick an ice cream cone, but some don't. So we got to be able to talk to parents and have us all on the same page about what's important, what's the goal, what are we trying to fix, and is our surgical technique what's needed or is something else needed? And then finally, the parental informed decision making. We want parents to understand the pros and cons of all the different options, including no treatment or including partial treatment, and we let them make the decision. How does research influence some of these things? This approach is something that we've come up with or that we've modified over the past 7-8 years, and it's really informed by all these boring documents here that no one really wants to read, but they all actually have a lot of really good information. It's not maybe information you agree with, but it is good information, and it's important to look across all of our different professional groups that we want to collaborate with, ENTs, pediatricians, pediatric dentistry. ICAP over here is the International Consortium of Ankle-Frenulum Professionals, and that has dentistry, manual therapy, osteo, lactation, ENT, peds, SLP, and it's an international group and consensus statement. So when we look across all of those, and we always talk about, oh, well, the pediatricians are getting down on us, and they don't believe anything that, and I know they just had a consensus statement that came out in 2024 that says, okay, tongue tie is now a thing. We've officially blessed it and recognized it, so now we can start talking about it. And all the rest of us are looking at them like, what have you been doing for the last 10, 20 years? I get it, the snarkiness is there, but we also have to look past that. And you might find that we all agree on more than what we would think. So amongst all of those statements, there are interdisciplinary teams of healthcare professionals. So Reza was talking about collaboration. That's what this whole group is here. That's why we're all here today. So interdisciplinary care, absolutely. But you can't just say it, and you can't just put people next to each other and hope that it just happens. I'm sure osmosis happens a little bit, but I appreciate Reza's comment about making sure that we make connections, and I would love to make some connections with all of you as well. We want thorough assessments by experts and validated tools. So we want people to use things that are validated. How do you measure outcomes? When you use a radiograph or you're using different dental materials, like how do you know that you're actually seeing what you're supposed to see, or how you're using the material the right way? Well, the same thing goes for how do you assess your surgical procedure. If you're just going to ask the parent, like, are things better, yes or no? Perfect, 100% parents say things are better. That's good enough. We've got to be more organic and more defined about what that is. And there are validated tools out there. Yes, they're tedious to administer. We'll talk about one of them today. But we want to make sure that when you report stuff or you tell your colleague, like, this procedure really worked, you got to be able to tell, like, it worked in these aspects, it didn't work so well here. We got to be able to sort of look at our warts and go back and move forward through that. I've seen the paradigm shift a lot. It's more about function and not looks. So they can stick out their tongue and they're gaining weight. There's got to be more than that for infants. So we've really seen the paradigm shift a little bit, and now we're looking about, can they lift their tongue up? How good is the tongue to palate contact? And we have a lot of airway specialists here that I'm sure will go into some of that as well. Conservative treatment before surgical techniques. Don't just jump to surgery, and I think that's what a lot of people think. Dentists with lasers have a certain stigma about it, so and we want to make sure that we don't promote that. But in our practice, the reason we want you to see a specialist, a lactation or speech pathologist or someone before you come to us is because you may be able to solve the problems without all the surgery. And now that we know a lot more about stretches and the importance of all that, that's really a good talking point for parents. Treat for problems now, not in the future, and then not every tie needs to be treated now, maybe in the future, but there has to be a rationale for doing this rather than just, oh, I'm sure it'll benefit you somehow. So current functional limitations, not appearances. These are all things that we've talked about, but we do use validated measures, and we use a couple other homegrown measures of symptoms to sort of track our outcomes and see where we're going, and to be able to critically evaluate the success of our treatment. So this is one of my slides that I use when I talk to parents, and this is something that has been growing over the past couple of years, and the terminology about anterior and posterior ties was a topic of conversation. So parents come in with half-baked ideas or half the information, so we try to talk about the anterior ties and how those are sort of the traditional things that pediatricians are looking for. That's the thin one in the front. There's a posterior tie, so I go over here and talk about that big fat part in the back. That may not be recognized as a tie. And then we talk about patients that have both an anterior and a posterior component, so you can see the thin part and the thicker part, the thin part and the thicker part, the thin part, thicker part, thin part, thicker part. And this is a really good slide for parents to understand what we're talking about. In 2019, we had a paper come out, Miller et al. This is really, I think, where we turn the corner in terms of understanding anterior and posterior ties. And when you look, you have this layer of fascia, but you also have some of the underlying mucosa that kind of gets pulled in there, and sometimes you get the muscle that gets pulled in there also. So when we talk to parents about, well, we can just snip it with a pair of scissors, a lot of times you're talking about just sort of this tie here, where we have sort of this overlying mucosa, and you just cut the mucosa, and a good example of that is this one down here. When we start getting the fascia or some of the muscle pulled in underlying, that's where you start to see these things over here. And it's important for parents to understand that it's not just cut it with a pair of scissors and we're done. Cut it with a laser and we're done. There's a lot more under there. It's a lot of muscle. There's a lot of vasculature that we have to avoid. There's nerves and things like that. So this paper really helped us turn the corner, and being able to explain that to your patients and let them understand the complexity of what we're doing here, it really is going to benefit you and it has benefited us to be able to tell them it's not just cut and we're done. We start the surgery, you finish the surgery. If you don't do your part, this surgery is not worth undertaking. So, and we have really changed the way that we interact with parents and patients and spend a lot more time with them to make them understand that. And if we feel like that's not going to turn out well, and you all feel it in your heart and your gut and every other body part, I suppose, you just know this is going to be a train wreck, then we put the brakes on and we just respectfully address what the concerns are, and we will not proceed with surgery until we're sure that we're going to get a good outcome, because we know how important it is for these stretches and things like that. We do a lot of labial frenectomies here. You can see the pre and the post up here. And so our functional criteria is that we want the lip to have enough mobility to occlude the nostrils without any blanching of tissue. That's the criteria we use, and I'll show you the data and results from that to support that surgical technique. And I know that's controversial for some people. When we do the tongue, we release the tongue until we can push the tongue. The tip of the tongue can be pushed to the posterior half of the palate with minimal lifting of the floor of the mouth. We feel like that's a good range of motion standard that we revise to. The criticism has been, well, maybe we're over-revising, but I would say that when we go to this standard, everyone gets what they need to have function. We don't leave anyone behind. If we release to a lower standard, we may start to see patients that didn't get revised enough, and going and having that conversation about a second revision is something that no one really wants to have. All right, hopefully I'm moving fast enough. In terms of our stretch protocol, so we've done the surgery. We do use a CO2 laser, and we talk about scissor releases or laser releases as diode and CO2 and so on and so forth. I think when you think back to that Mills paper, the question is, can you get to the bottom of the tie and do a full release Whether you use a scissors or diode or a butter knife or whatever you want to use, however you can get there, make sure that you're doing it well, you're surgically conservative, and you have the patient's welfare in mind. But I think the biggest question right now is, do you need to release all the way to the genioglossus muscle, which we do. Some people leave a layer of fascia, some just clip just the minimal layer so you don't get bleeding and all this other stuff. I think that's still a topic of debate. So, but what we do know is that stretches are important. So we get a lot of patients coming from ENT for second revisions. ENT went in there, clipped it with a pair of scissors, and you know, didn't offer any stretch protocol. Just cut it, it'll be fine. Well, we all know what oral mucosa does. We all know that it heals really quickly. So when you don't do a stretch and you're not trying to move towards keeping that site open and having it heal a different way, reattachment is definitely a possibility. I think that one of the biggest research questions I still haven't been able to answer is, why didn't you go back and say something to them? I always ask them, and I do understand that. You know, we're talking about parents who are vulnerable. They have their infants had clips, you know, with a pair of scissors. ENT is a medical doctor. They're a medical professional. They're well respected, and no one really wants to go back and be like, hey, I don't think what you did works. But we do have patients that talk about no improvement in breastfeeding or transient improvement in breastfeeding. I don't have that data panel up here, but we do have data that shows you need to be checking out to about 1 month or 3 months to start to seeing trends of things recurring and going back to the way they were. But a lot of times these doctors don't follow up. They see them for a week, things look good luck. Things are going well, but then at 1 month, things start falling apart. 2 months, it's kind of back to normal, and we're still having the same problems. And so that was some of what our other research showed. For our current stretch protocol, so after surgery, we encourage parents starting on day 1 to 14 or weeks 1 and 2 post-surgery. We want them to do stretches every 4 to 5 hours around the clock. Each set of stretches is 3 repetitions of 3 seconds each. Take the lip, push it all the way up, lift from the base of the lip and occlude the nostrils, hold for 3 seconds. Or, and those are surgical standards that we went for, or take that tongue, push it all the way to the posterior palate. I know babies gag, I know they make these awful sounds. Hold it for 3 seconds and repeat. Weeks 3 and 4, you can just do 4 sets of stretches during the day. This is our current protocol that I'm sharing with all of you. No set intervals, so just do them. I use breakfast, before lunch, after lunch, dinner, breakfast, lunch, dinner, sleeping, whatever you want to do. And we feel like that's for minimization of scar tissue and deeper healing to kind of maintain flexibility of the tongue. I don't care if it takes longer for the surgical site in the long term to heal. I want to make sure we maintain flexibility in the early course of and moderate course of healing. So everyone has their own set protocol. None of them are standardized. Everyone has different ones. Some are reported, some are not. Some do before surgery, some do after surgery, some do before and after surgery. We're looking into some of that. I work with a whole bunch of folks at Curtin University in Australia, and we're working on some of that together, so we're looking at that. But this paper came out in 2025, early 2025. These are scissor releases, and they looked at people who were completely adherent with stretches, and ones that didn't have any stretches at all, and then ones that were in the middle. And the most important parts of all these here is that when we looked at those who were stretching adherent, they had 0% had persistent feeding difficulties. Out of 36 patients, none of them had persistent feeding difficulties. Some of them had recurrent ankyloglossia. Some of 2 out of 36 required a second revision. So I think that's within the margin of error. I don't think any surgical technique is 100%. We will, under the best conditions, still have some recurrence, but that's okay. And that's a conversation you have to have with parents, that even under the best circumstances, we may still have a chance, and that I think is reasonable. I think most patients and parents would understand that. When the ones that had no stretches, we always had heard coming out of, we had heard but not seen published literature that talked about scissor releases and, oh, you just snip it, it's perfect, and there's no problems. Yep, that's great. Anecdotally, that's great, but where's the research? Where's the real numbers that show us that that is the case? And so now when we start having these papers come out, those who had no stretches, 16% of them had persistent feeding difficulties, 16% had recurrent ankyloglossia, and 32% of them, almost a third, required a second revision, which again, that's the kiss of death. None of us want to have that conversation with parents. So we're starting to get more data to support some of what we're looking at. I don't think that you can't do scissor releases, but I do think that when we go back between the Mills paper and this one, we are looking at trying to understand what exactly is the surgical technique that we can set as a standard to get the lowest recurrence rate and the lowest amount of second revision requirements. Compliance with the stretches with compliance with stretches group had the lowest percentage of adverse outcomes. What's weird about this data here is right here in the middle, the ones who sort of did some of the stretches but didn't had the highest rate of recurrent ankyloglossia. So we have to look at see what the real outcomes are and really deal with data that we can't explain, but that is real, and we need to figure out what to do. We can't just explain it away with, well, those babies needed body work, so all of those babies weren't ready, so that's why it came out like that. We can't do that. We can't, we're past the time where we can just make those blanket statements, and we really need to kind of address some of that. So we do a lot of mastery of stretches, and when we use our model, this is Tyler. This is a sort of a model with different tongues and palettes that you can interchange in there. It's available from Lactation Education Resources. I don't work for them. It's exorbitantly expensive for what it is, and it's not super awesome, but it works, and it's a good tool for parents, some of them, I guess. So we use that, and we have them practice on that. And then you see us here where we're teaching parents how to do stretches. And we actually, one of the changes we made is we now actually do the stretches right after surgery, and we have to parents put their fingers in the mouth and figure out what it is. You can tell them, you can have handouts and Facebook and all that, but it doesn't really work unless you get through all that stuff with that. Have their hands in their mouths. How do we come to our stretch protocol? It's guided by research and other studies that are coming out. So when we look at the information from some of the studies that have come out about how much we have to support parents, we know that that's super important. When we look at case studies from our practice, and we look and see, what's the average percentage at 4 weeks, 74.6% of reported symptoms are resolved in the general population of our kids. When we looked at ones where we know and documented that they missed stretches, that's what's listed here. And the take-home message here is that if you miss stretches during the 3rd and 4th week, where we talked about not having regular intervals but just minimizing scar tissue, you'll see some attenuation. You'll get good results, but you won't get maybe the best or the average result of what we see. If you miss stretches, like this patient missed the whole 2nd week because of COVID. The whole family was just knocked out. In that infant, they resolved 0% of their symptoms at 4 weeks and added 1 symptom. All right? So we delved into that a little bit more, and we found another case here. This is a family that totally didn't listen to what I said. I know that's shocking that maybe parents don't follow your instructions completely to a T. And they're like, we'll do stretches every 3 hours during the day, but I know my baby, I'm gonna let them sleep at night, and also I'm lazy and I don't wanna get up. That's a little judgy. That's a lot of shade to throw. So, okay, well, whatever the reason was, they didn't do any stretches at night. So they did it perfectly, followed all the regs. Like here, they didn't have a problem because there's no night stretches. But remember, the first 2 weeks, it's 24 hours a day, 0% resolution, and added 11 symptoms at the 4-week mark. This was both of these, but really this one was a very unpleasant conversation to have because it had tightened up, and now you're in the middle of a wound healing process. And I tell parents that I really don't like to go in. I'd like to let the wound healing process take its course because we're in uncharted territory. If it's healing, then we cut it again with a laser and it comes back even harder with more scar tissue. It's really disheartening to tell them they're gonna have to wait 3 or 4 months and struggle with what they have because they didn't do what we told them to do. That's a harsh conversation, but it is one that needs to happen. So our take-home message and why we really stress our protocol is that you cannot miss a stretch in the first 2 weeks. Every 4 to 5 hours, you can do it more frequently, and anecdotally, the parents who are on point and doing it every 2 hours, which is unimaginable, but okay, 2 hours with an infant around the clock, get amazing results, and we're gonna start to write that up as well because again, there's very few parents who are willing to do all the reporting and give us that information and commit to doing it every 2 to 3 hours, but they are out there. This is some of the work that we did with Curtin University. In short, what it says is that we want to make sure that we empower parents. They are just as important as the surgical technique. The back end of this and empowering them is really important. We talk about validated tools. This is the Infant Eat. This is the current tool that we use, and you can see all these different symptoms. This is a validated tool, so each score, you tabulate this up, and each domain, which is listed by these green bars here, each domain, there are 9 of them, that measure breastfeeding dysfunction in infants. It's validated for infants up to 7 months, which means they looked at thousands of babies that had problems, thousands of babies that didn't have problems. This panel of questions is what helps differentiate that. It's validated. If they're under 2 months, there's a set of standards, a different set of standards for 2 to 4 months, 4 to 6 months, and 7 months. And when you think about all the courses that you've gone to and you hear about these tools and things that you can use, like these people went to Harvard, they went to Stanford, they went to all these great places, make sure you're looking to see if those tools are validated or if it's just their opinion. And I get it, tools are nice, they make them look really pretty, but the meaning behind it is important in terms of what you want to be able to say to your patients and guarantee outcomes, or at least give them an informed opinion about that. When we look at here, this patient started here, this is pretty typical. The green boxes show where we want to end up. We want these to be almost always or always, and we want these to be never or almost never, which are all the symptoms. You see all these things here. We code it, it's like a traffic light. Green is of no concern, yellow is moderate concern, red is high concern. And you see all those things, and those are standards given by the test. And then over here, you see everything in the green. This is, I believe, at 4 weeks. Look at how much things have changed and how powerful your surgical technique can be if you're administering it under the right conditions. This is a lot. Okay, everyone still with me? I got 5 minutes to cram in all the rest of the stuff. All right, so when we look at effects of lactation and bodywork, this is an ongoing study that we're doing in our practice, and I will just break this down for you. We had babies that had, we just divided them into convenience samples. Some get the surgery only, some, because we do not require lactation and bodywork, we just highly recommend it, but there are financial resources, and sometimes that doesn't allow for things or other circumstances. Babies who had surgery only, babies who had surgery plus lactation, babies who had surgery plus body work but no lactation, and babies who had body work and lactation. You've all heard the people out there that say, if you don't get the body work and you don't get the lactation, forget it. Don't do the surgery because you're not going to get the results that you want, and you're not going to get the best outcomes for them. This study has been ongoing for several years because these numbers are really hard to get in our patient, but we're getting ready to do a multi-center international study with this, so we finally got that in place, but I'll just break it down for you. On average, 74.6% of symptoms are resolved if you get the surgery alone. No lactation, no bodywork, nothing else. Surgery only, 4 weeks, resolve 74.6%. When we do the ones with lactation though, and by the way, 74.6 sounds great, and parents are really happy about that, but the resolution of symptoms is anywhere from 12% to 100%. I call this Vegas odds. You may win big or lose big, but you'll get something. Everyone improves, but you may improve by this much, or you may resolve everything. So I don't know how parents would react to that if you tell them you might resolve 12% of your symptoms or 100%. And in fact, the patients that didn't follow the stretch protocol, those ones aren't included in this. Otherwise, this would be at 0 or negative something. Anyway, when we look at those who have frenectomy and lactation, 90.13% with an average of 81 to 100. This is the statistics that I use and the research data that I use in my consultations to tell them, if you have the resources to get lactation support, get it, because your percentage and your rate of success is going to go way up. The part that I can't explain, which hopefully someone here can later, when we look at frenectomy and bodywork, now this is a very low number of patients, but patients who have frenectomy don't want to get lactation, but somehow can get bodywork or chiropractic care, 86% resolution, which is better than this, almost probably similar to this. We don't have enough statistics numbers in the group here to make that comparison, but looks like things are really good. Here's the kicker. When we look at those who follow that model, this is going to be perfect for your baby. You need to get the body work, get the lactation support, get all that. The average is 64% resolution. Is it possible that we are overloading infants with too much stimulus at one time? This is not a very popular number internationally, for sure. When we presented this, we got a lot of flack. Well, maybe those babies weren't ready for that. Well, we would have seen that in our statistics then when we looked at the symptoms, and we looked at, we would have expected a higher number of symptoms. Well, maybe they had more symptoms than the other groups here. not true. These percentages are based on the total number of symptoms that are resolved out of the total number of symptoms reported. So we look at it as a percentage. That's how we standardize all of that. I don't have an answer for it, but I want you guys to know that. And these numbers are sound, and we've analyzed it several different ways, and we can't come up with an explanation. But this speaks to exactly where we're at, right? Like, we're here. We know that frenectomies work. We now need the nuances of when do we recommend body work? When do we recommend timing of body work? Do we need it? Does everyone need it? We don't have those answers, but I think this is the group of people that will be able to answer those types of questions. When we look at speech and eating issues, here's what, and Baxter has looked at this before, but his outcomes are sort of like, speech got better, this got better, that got better. So we looked at a little bit more in terms of outcomes here. These are the percent resolutions that we saw in 50 patients. These are eating issues. And at 4 weeks resolution, this was the percent resolution for each of these. This is still prelim data because we want more, but we definitely know that tongue tie surgeries and therapy helps these kids eat better and speak better. And here are the speech resolutions as well. All right. Do they get access to these slides? Or?
Yeah, they do.
Okay.
The entire day is recorded.
Excellent. Perfect.
Slides, if you want it, we can be the conduit for PDFs.
Yes.
For that version, if anyone wants that, but we'll have, it's going to take a while to edit and get it up on our website, but it'll be on our website hopefully by the end of the year.
I hate to cut you off, but we don't have time for your talk, Rick, so sorry. All right, so I'm already a little over here. So here today, gone tomorrow. Do we revise for okay, I'm sorry, dude, that's my bad. Do we revise? I told you already, I gave you the answer already. We don't revise for future things. When we looked at our studies in our patient population, we looked at eating. Over here on this side, the ones that we looked at pediatric dental patients that did not have a revision. So these are 2 to 5 year olds. We're asking, has your child had speech or eating issues? Did they have a frenectomy when they were an infant under 1 year of age? The take home message is no difference. You do a frenectomy on an infant for breastfeeding problems, they have the same risk of speech or eating issues. Granted, it's a small risk, but they have the same risk of speech or eating issues whether they had a frenectomy or not. So we really have to get away from saying, this will help your child not have speech problems later. We should do it. What I say to my patients is, your infant, your baby here has an appendix. We should go ahead and take their appendix out so they don't have appendicitis. Then after all the horrible comments and the looks that I get for being just a butcher and like terrible person for suggesting that, they get it. It's like, why don't we wait until we see symptoms of speech or eating or appendicitis and fix it then? Why are we putting your baby through this now when we could fix it later, and the majority of your kids won't need that? Last thing about lip ties, we looked at restrictive lip ties. Oh, we're gonna do this now so they don't get cavities in the future. Here's what it looks like when in kids who had really no lip tie or non-restrictive lip tie, 26% present with some sort of decay, decalcification, anterior teeth. That's pretty consistent with what we see in the literature. The ones with a restrictive lip tie, no significant difference. Why are we clipping infant ties when we're saying they're gonna have problems with cavities? We can just deal with that later. And that's not a guarantee, and I think this is just one of those things that sort of people think but don't necessarily have evidence to back it up, so that's what it looks like. I will finish with this. In our huddles, everyone's all serious. This is used to kind of get the glaze off everyone's face. What do you call a hen looking at a bowl of lettuce? Chicken Caesar salad. Yeah. All right, everyone's awake. Let me finish up here. This is not a fad. It's gonna be around. When we think back to that person who's like, yeah, I saw it. It's all the same stuff. I'm out of here. There's nothing new. Not true. We have a better understanding of what constitutes a tie and how to diagnose it. We have a developing view of lip, tongue, and buccal ties, and we're learning how that's going to affect our practices and how we counsel patients. We know the importance of stretches and follow-up, and so anyone who's doing these without going any stretch regimen, you're on the wrong side of the tracks here. And we know parental support and best outcomes are possible, but we need to pay more attention to that. When we put it together clinically, function not looks, informed decision making, all this stuff, you can read it in the slide, and then my acknowledgements here. Thank you guys.